Dr. R. Gerald. He's a consultant cardiologist at Teaching Hospital Jaffna. He's going to be following on to that first talk by talking about the physical activity and exercise for a cardiac patient. Over to you, Gerald.
Good morning to all. I am Dr. S. Gerald, acting consultant cardiologist at Teaching Hospital Jaffna. First of all, I would like to thank Sri Lanka College of Cardiologists for giving this great opportunity. Today, I am going to discuss physical activity and exercise for a cardiac patient. Please bear with us, there may be some overlap. First of all, we see this definition of cardiac rehabilitation. Cardiac rehabilitation has been defined as the sum of the activities required to ensure cardiac patient the best possible physical, mental and social condition so that they may by their own effort resume and maintain as normal a place as possible in the community. Cardiac rehabilitation has been described as the combined and coordinated use of medical, psychosocial, educational, vocational, and physical measures to facilitate return to an active and satisfying lifestyle. The cardiac rehabilitation is a coordinated, multifaceted intervention involving several people: dietitian, cardiac nurse, cardiac specialist, physiotherapist, psychologist. They all try to make lifestyle changes, thereby improve quality of life, restores confidence and function, prevent further recurrences. First of all, we will see this physical exercise and this mortality. The regular exercise is associated with lower mortality from both cardiovascular disease and all-cause. Risk of coronary artery disease was less than half in the most active compared to this most sedentary individual. No clear consensus on the health benefit of vigorous and prolonged exercise compared to more moderate physical activity. Exercise energy expenditure of greater than 2000 kilocalories per week provide no additional health benefit. Most evidence is for aerobic exercise, but recent observational studies suggest resistance training also has favorable effect on cardiovascular risk. Regular exercise associated with the significant 28% reduction in all-cause mortality and a possible but non-significant 24% reduction in recurrent myocardial infarction. Then just we will look at this effect of habitual physical activity. It will increase in maximum oxygen uptake and cardiac output and stroke volume, reduce heart rate at given oxygen uptake, reduce systolic and diastolic blood pressure, improved efficiency of heart muscles, decrease myocardial electrical irritability, reduce mortality around 26% and morbidity, increase capillary density in skeletal muscles, increase activity of aerobic enzyme in skeletal muscles, reduce lactate production at given percentage of maximal oxygen uptake, enhanced ability to utilize free fatty acid as substrate during exercise glucogen survey, improved endurance, increased metabolism, increase in the HDL-LDL ratio, improved structure and function of ligaments, tendons and joint, increased muscular strength, reduced rate of perceived exertion at given work rate, increased release of endorphins, provide a sense of well-being, enhance tolerance to hot environment, increased rate of sweating. Moreover, reduce platelet aggregations, counteract osteoporosis, can normalize glucose tolerance, improve endogenous and exogenous insulin sensitivity, decrease percentage of body fat, increase lean body mass. Then, before we are going to recruit patients, we had to have some risk stratifications before exercise training. Just we will go through the low risk categories. If the patient comes with after 4 weeks of MI, they don't have no or mild dyspnea on exertion, no ischemia or angina at or below 5 minutes of exercise, appropriate increase in systolic blood pressure, no ventricular ectopic, patient has recognized symptom of ischemia and self-monitor exercise intensity. In case of moderate risks, if the patient comes with less than 4 weeks after MI, whether they may have 2 or more previous MI, dyspnea during usual physical activity, exercise capacity less than 6 minutes, falling systolic blood pressure during exercise, ischemic decompression more than 3 mm or angina during exercise, previous episodes of primary cardiac arrest or ventricular tachycardia, or patient may have triple vessel disease or left main stenosis, or patient may have low ejection fraction. In case of high risk category, patient have unstable angina, ongoing chest pain, or decompensated heart failure, uncontrolled arrhythmias, or presence of other cardiac condition which may aggravated by exercise, such as aortic stenosis, hypertrophic cardiomyopathy. And then just we will move to this risk of exercise. This is very important because this vigorous exercise may trigger myocardial infarction or sudden death, and regular exercise protect against this. The risk of myocardial infarction is on average 6 times higher during and for 1 hour after vigorous exercise. That's why we have to be very careful. The vigorous exercise, ideally, it will trigger myocardial infarction. The risk is high in person with impaired left ventricular function, severe coronary artery disease with inducible myocardial ischemia, recent myocardial infarction, and in individual with significant ventricular arrhythmia. We will move to this exercise in specific conditions. If the patient comes with angioplasty and stenting, although regular exercise is likely to reduce long-term risk, no studies reliably assess whether exercise training influence outcome following PTCA. There is also limited information on the safety of early after coronary angioplasty and stenting. What about coronary artery bypass grafting and other cardiac surgery? The cardiac rehabilitation with exercise may more rapidly improve functional capacity following coronary artery bypass surgery, particularly in patients with physical deconditioning. Exercise is normally limited during the early weeks until there is adequate healing sternotomy and surgical incision. But low-level activities, for example walking, can usually 48 hours following surgery with gradual progression. In the long term, regular exercise is likely to reduce cardiovascular risk. Arrhythmias. The effect of exercise training in Person with arrhythmia is uncertain. The presence of exercise-induced high-grade ventricular ectopic is usually a contraindication to vigorous exercise. For a person with a benign arrhythmias, exercise training is not contraindicated. Pacemaker should not restrict physical activity. For many patients with the pacemakers, heart rate is not a reliable guide to exercise intensity. Indications such as perceived exertion need to be used to guide appropriate level of exercise. We have to consider these older people actually much less likely to be referred for the cardiac rehabilitation than younger groups. Both male and female older persons with established coronary artery disease can improve exercise capacity with training comparable to younger group. Finally, we will move to these exercise prescriptions. An individual approach is needed because of this wide range of age, fitness level, disease severity, risk factor profile, and medication. While we are considering prescribing exercise, 5 major components we have to keep in mind: frequency, duration, type of exercise, intensity, warm-up, cool-down. The intensity and duration of exercise session should start at a low level and gradually increase. Frequency. Most exercise prescriptions are modified from a 3-session per week model. Patients with low functional capacity are encouraged to take part in several brief exercise sessions each day, around less than 10 minutes. Patients with higher functional capacities will benefit from fewer longer sessions. Patients' program may start out with several short sessions each day and gradually increase into 3 to 5 and 30 to 45 minute sessions per week as functional capacity improves. Duration can be adapted from a baseline value of 30 minutes per session. The type of exercise to achieve the best aerobic training effect, prolonged continuous low to moderate intensity. Exercise using large muscle group is indicated like walking, running, cycling, and swimming. Exercise intensity. Low to moderate intensity exercise is beneficial, and increased benefit may be achieved with more intense exercise. Finally, I am going to summarize. Exercise advice should be individualized and consider clinical characteristics, lifestyle, attitude, culture, and environment. For sedentary people, at least 30 minutes of moderate intensity activity on most days of the week is recommended. Physical activity for people with a coronary heart disease should begin at low intensity and gradually increase over several weeks. Short period of physical activity are beneficial. In patients with coronary heart disease, vigorous exercise is generally not encouraged. Conclusions. If there was a pills that cost very little, reduce cardiac death by 27%, improved quality of life, and reduce anxiety and depression, every cardiac patient would be expected to take it. Ideally, there is no such pill, but taking part in a cardiac rehabilitation program can provide all these benefits. Thank you.
Thank you very much, Gerald, for that excellent talk. And I think that's a very, very important point that you gave in that last slide as well. I don't think we need pills for those kind of things. So if we can actually establish good cardiac rehabilitation programs in this country as well, there'll be very, very good outcomes. Just a reminder, I think I'm getting a few questions regarding the talks, whether they are uploaded onto the system or not. And I was told that at the end of the day on the website, Sri Lanka College of Cardiology website, all these lectures will be uploaded for you to download. Over to Sandamali for the second half of the symposium.
Of course, thank you, Chamara. Our next speaker is none other than my co-chairperson.